Good afternoon, and welcome to my Institutional Review Board presentation for APN 615, Nutrition and Metabolism. My name is Lauren Sullivan. I'm a registered dietitian, and my presentation discusses the effects of 3 different doses of vitamin D after gastric bypass surgery. Vitamin D is a topic of interest for me both personally and professionally. As you can see, I have been blessed with very fair skin, and no, I'm not anemic, just very fair. I also live in the northern hemisphere of the United States. I work full-time and I attend school, so I'm rarely exposed to sufficient sunlight, and I am frequently in need of vitamin D supplementation. Professionally, I work with bariatric surgery patients on a daily basis, and I see the epidemic of hypovitaminosis D that is frequently described in the literature. The title of this IRB proposal is The Effect of 3 Different Doses of Vitamin D3 on Serum 25-Hydroxyvitamin D Status for 24 months following Roux-en-Y gastric bypass in women ages 20 to 40 years. The main purpose of vitamin D in the body is maintenance of normal serum calcium and phosphorus levels needed for a healthy, strong skeletal system. This includes normal bone growth, bone mineralization, and it also reduces inflammation and functions in the immune system. Obesity is a risk factor for hypovitaminosis D, and bariatric surgery is a frequently selected option for the treatment of obesity. Studies have shown that up to 76 to 90% of pre-surgery patients have hypovitaminosis D. One common bariatric surgery is the Roux-en-Y gastric bypass. It alters the anatomy by bypassing the entire duodenum, the upper part of the small intestine, and this creates a permanent change in the absorption for calcium, phosphorus, and vitamin D, and this leads to osteomalacia and bone demineralization. High-quality studies to determine the efficacy of multiple vitamin D regimens following Roux-en-Y gastric bypass are lacking. Therefore, the proposed research question addresses this gap in the literature. The research question is, do 3 different doses of vitamin D3 supplements in women after Roux-en-Y gastric bypass surgery improve vitamin D status at 6, 12, and 24 months following surgery? The null hypothesis states there is no difference in the 25-hydroxyvitamin D levels in females ages 20 to 40 years, receiving either 3,000, 5,000, or 6,000 IUs a day of vitamin D3 supplementation at 6, 12, and 24 months post Roux-en-Y gastric bypass surgery. The alternate hypothesis states there is a difference in the 25-hydroxyvitamin D levels in females ages 20 to 40 years, receiving 3,000 versus 5,000 or 6,000 international units per day of vitamin D3 supplementation at 6, 12, and 24 months post Roux-en-Y gastric bypass surgery. It is very important to have a comprehensive understanding of this nutrient. Vitamin D is obtained from food sources, including liver, eggs, fatty fish, butter, and fortified foods like dairy products, dairy alternatives, margarines, and cereals. Vitamin D may also be consumed through supplements, but it is mostly obtained through cutaneous synthesis from ultraviolet B radiation exposure. I have to say that I'm a little jealous at the moment. 2 of my daughters are exposing themselves to UVB rays in Myrtle Beach as we speak. Vitamin D presents itself inactively until a hydroxylation reaction converts it to active vitamin D, and this occurs in 2 places, the liver and the kidneys. The liver forms calcidiol, also known as ergocalciferol, vitamin D2, or 25-hydroxyvitamin D. The kidneys form calcitriol, also known as cholecalciferol, vitamin D3, or 125-dihydroxyvitamin C. In summary, there are multiple factors causing low vitamin D levels in persons with obesity, including things like the storage in the adipose tissue, lack of exposure to UVB rays, and poor dietary choices. When a person selects gastric bypass as an option for the treatment of obesity, changes in anatomy, metabolism, and absorption lead to deficiencies. Studies have shown, and they've many studies have tried actually to give the safe and ideal range that is used in practice to prevent hypovitaminosis D in bariatric surgery patients. Moore in 2014 and Goldner in 2009 led prospective studies that respectively determined that 2,000 international units of vitamin D per day is insufficient, and that 5,000 international units is effective in preventing deficiencies, but is not sufficient for some patients. Hollick in 2011 and Mechanic in 2013 led meta-analysis reviews to establish practice guidelines for the Endocrine Society and for the American Society of Metabolic and Bariatric Surgery, respectively. Hollick determined that 6,000 to 10,000 international units per day is needed for patients with malabsorptive syndromes, and that includes Roux-en-Y gastric bypass. The American Society for Metabolic and Bariatric Surgery was much less aggressive and deemed a dose of at least 3,000 international units per day as the recommended dose following bariatric surgery. Lazzarini essentially dosed 1,500 to 1,600 international units per day and determined that the level was insufficient. Vicks and colleagues in 2014 strongly recommended aggressive pre-surgery treatment and suggested future studies to evaluate vitamin D regimens in post-op patients. Other studies have been unable to determine the optimal dosage, but it has been clear that levels below 2,000 international units per day are not enough to maintain serum 25-hydroxyvitamin D levels of at least 30 nanograms per milliliter. This study is randomized and prospective, and the 3 study doses of cholecalciferol are 3,000 international units per day, 5,000 international units per day, and 6,000 international units per day. The subject recruitment will include female patients ages 20 to 40 years that complete a multidisciplinary clearance, also approved for Roux-en-Y gastric bypass and scheduled. Subjects not meeting the age and gender recruitment goal will be excluded. Other exclusions will include women already in menopause, previous bariatric surgical history, and medical diagnoses with conditions or medications that alter metabolism for vitamin D. Provisions to protect personal health information have been made. The study will be taking place at the facility that follows the Health Insurance Portability and Accountability Act. The electronic medical record will use to consent patients, so there will not be a paper trail compromising confidentiality. The facility is also awarded the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, also known as MBS-EQUIP, and this designates the program as It designates that the program has a proven record of favorable outcomes for weight loss surgery. The consent process will take place in person 1 to 2 weeks prior to surgery. HIPAA will be reviewed with the subject, and the subject will be provided with a written copy of how the data will be collected and used, and receive the researcher contact information in case they need to contact the researcher at any time. Subjects may withdraw from the study if they choose. The research will be conducted at a large MBS-EQUIP academic medical center. 150 subjects will be consecutively enrolled beginning in January of 2020. At the introduction of the program, all bariatric surgery patients will have labs, anthropometrics, and demographics drawn. That's standard for a protocol in our surgery department. But those who are consented for surgery will also have additional labs drawn 2 weeks prior to surgery at 6 months, 12 months, and 24 months. And those will include labs, body composition, and the consent. The vitamin D treatment will begin prior to surgery on all patients. So patients who have a slight deficiency, 25 to 30 nanograms per milliliter, will receive 2,000 international units of vitamin D3 per day until surgery. Those that have an insufficiency, having levels of 20 to 25 nanograms per milliliters, will receive vitamin D2 in the dose of 50,000 international units per week for 8 weeks. Those who have severe deficiencies of less than 20 nanograms per milliliter will receive vitamin D2 in doses of 50,000 international units per week for a period of 12 weeks. All of those patients will receive 1,200 milligrams of calcium carbonate per day until surgery. The subjects will be randomized into 3 groups. Vitamin D treatment will start 1 week post-surgery, and each group will have 50 subjects. Vitamin D3 doses are 3,000, 5,000, and 6,000 international units per day, and all subjects will also take 1,500 milligrams of calcium citrate per day. All subjects will also receive the recommended supplements per guidelines from the ASMBS. There may be risk associated with this study. They're minimal, and they include potential for hematoma or infection related to the lab analysis. It also may have some risk associated with injury during the bioimpedance analysis for body fat percentage, or injury traveling to and from the medical center. Adverse reactions may happen with supplementation, or there might be insufficient supplementation. There is a potential at any time for a confidentiality breach, but those have been minimized. There are benefits associated with this study. Compensation for the study is about $1,000 for each participant, each subject, including parking vouchers for the follow-up sessions and free vitamins and minerals for the length of the study. Also noted is close monitoring of the labs and health status in this process. The data will be analyzed, and a G-Power analysis was done prior to the study. A total sample of 47 subjects was deemed appropriate. It was increased to 150 patients for study strength, and this allows for an N of 50 in each group. A 95% confidence interval with a medium effect size of 0.05 and a p-value of 0.05 was used for analysis. A goodness of fit test with a priori analysis was completed, providing a critical value of 1.680374, and the Wilcoxon signed rank test was selected for analysis for a matched pairs t-test. The data will be analyzed by an expert at the facility. The Institute statistician will use quantitative descriptive statistics, and the evaluation will include percentage of weight loss, change in body mass index, change in lean body mass, changes in laboratory values including serum 25-hydroxyvitamin D, calcium, alkaline phosphatase, albumin, intact parathyroid hormone, and urine albumin creatinine ratio. The aggregated mean, median, and mode will be used to summarize each of those variables. The independent sample t-tests, the means plus or minus standard deviation, will be used to report changes in the 25-hydroxyvitamin D levels, the percent lean mass, percent fat mass, and BMI, and between these data points and the demographic data, and between these data points in relation to preoperative vitamin D 25-hydroxyvitamin D levels. A one-way analysis of variance, ANOVA, will compare several means. Such a statistically significant difference between the means of the 25-hydroxyvitamin D levels between the 3 vitamin D3 subject groups at each follow-up interval, baseline, 6 months, 12 months, 24 months. There are greater than 2 population groups, so the t-test in this instance is not warranted. ANOVA may be used to compare the means of any lab value, body weight, body fat percentage, or BMI between the 3 study arms. The Kruskal-Wallis test will compare lab values between the 3 groups, and the Fisher's exact test will evaluate the change in vitamin D status between the study doses. A Pearson's correlation test will examine the relationship between 25-hydroxyvitamin D level concentrations and body mass index, and between percent body fat and lean mass. Simple regression analysis may evaluate 25-hydroxyvitamin D levels and the IPTH levels. A pairs comparison, Wilcoxon rank sum test, will compare the vitamin D supplementation of those in all groups and with and without deficiencies. Spearman's correlation coefficients will show the association between the change in laboratory markers of calcium and IPTH and a change in the 25-hydroxyvitamin D levels at baseline. It is hoped to offer conclusions related to vitamin D dosing in relation to percent body fat and related BMI. Other hopeful conclusions will be the relationship identified between vitamin D dosing levels and change in serum 25-hydroxyvitamin D levels compared to the expected changes reported in the literature. Study limitations may include inconsistencies in patients' reporting versus the actual usage of the supplements, so there might be some recall bias, and patients need to feel the need to report higher doses sometimes to show that they're meeting goals as expected, which might be social desirability biases. So the study is taking place in the northern climate, but the sun exposure is not also included, so that's an area that's lacking in the study. Thank you for listening to my data analysis and my study potential. The references are listed, and I welcome your feedback. Looking forward to hear from you. Thank you very much.